Good evening, doctor. Good evening, participants. Hope you all are doing well. Myself, Nihar Panda, an employee of Highlands, taking care of medical quality compliance section. Welcome you all to the special webinar, which is having two topics. Topic 1, diabetes mellitus in women, new insights. It will take 20 minutes. Another topic, topic 2, diabetes vascular diseases, new insights. Session time will be again 20 minutes. There will be a combined question and answer session that will be again for 20 minutes. Let me introduce our speakers for this webinar. Professor Abdul Hamid Jargar sir, who is the former chairman, Department of Endocrinology, SKIMS Srinagar. He was the president of Endocrine Society of India also. Next, our second speaker is Dr. Rajiv Agrawala, who chairs the Department of Cardiology at Jaswant Rai Specialty Hospital, Meerut. He was also awarded Lifetime Achievement Award by IMA Meerut. It is requested to all the participants to share the questions in the chat session only so that it can be addressed in the question and answer session. Now, I request our first speaker, Professor Abdul Hamid Jargar sir, to commence the session with the first topic, diabetes mellitus in women, new insights. Over to Professor Abdul Hamid Jargar sir. Thank you.
A very good afternoon, dear colleagues and friends and delegates who are listening to us this afternoon. For next 20 minutes, I'll try to give you some of my own perceptions that I have developed over the last few decades, looking at the data that has been generated in this part of the world and globally, that are there any genuine differences between men and women when we look at diabetes, biological or otherwise, and how I look at it. Why I said how I look at it? Because everybody may not look at it the same way. So I want to make it amply clear that I have a right to say after 4 decades of endocrine practice how I look at it. Rajiv, you agree with me? So, you know, first things first, if you look at the gender equality, if you look at how in the historical terms the two sexes started being equated, all of us would be amazed that it is in the recent past only that people started talking about gender equality, and throughout history and throughout millennia, the debate was on, but the gender equality was not there, and probably still is not there. That I'm going to tell you over the period of time. And a diabetic, let's say a type 2 diabetes in a male, probably, you know, apart from the vagaries of the age, many things do not change. But look at a female who develops diabetes during teenage, who develops diabetes during young days, who develops diabetes in an age where parents are looking for marriage, or in a lady who just got married in a subcontinental social context, and then got married, is developing diabetes or has developed diabetes, and then expects to get pregnant, or someone, you know, who has already got married, has conceived and develops gestational diabetes mellitus. So this makes it a totally different ball game at different stages of life. So a lot of newer understanding has come in what are some of those specific issues that you and me have to handle in women with diabetes. This nurses' health study was one of the first studies. It was a long 1.5 decades follow-up of almost 1 lakh of nurses and their health parameters. It was one of the first studies that showed that obesity is directly related to type 2 diabetes mellitus. And then hordes of studies started coming in and correlating obesity with diabetes mellitus. This is some data that me and my colleagues published about 2 decades back, looking at obesity in adults, and adult were defined 40 and above. You can see it from that in a semi-urban and rural Kashmir, 15% of the adults were obese. And then 2 decades back, we said obesity is far more common in women than in men. 23% against 7% in men. So this is a problem in everybody, but it seems to be a problem slightly more in women than in men, particularly in the subcontinent. Now, for last a decade, there is a global group of researchers who are collating their data together to develop some ideas of how non-communicable diseases, how coronary artery disease, how diabetes, how obesity, how underweight is doing in the last 30 years, 40 years, 50 years. And this group is known as NCD Risk Collaboration Group. NCD stands for Non-Communicable Diseases. And we have been a part of it for a long time. And this gets coordinated from Harvard Medical School and Imperial College London. And this is the data that our group published on trends in adult body mass index. It means obesity as well as underweight over a period of almost half a century, from 1975 till 2014. And this paper was published in Lancet, May issue of 2016. If you look in front of you, on your left side, you will find out obesity in men. On the left side is the data from 1975. Indian men stood at position number 19. You can see it, United States, Russia, Germany, blah, 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 and 19. So obviously not in the top of the table of obesity. But look at on your right side component of the table. 2014, Indian men stood at position number 5. From position number 19, we had gone up to position number 5, means obesity in terms of prevalence and overall numbers was significantly increasing in the country in men. Now, if you look at the other component of study, Indian women were again at position number 19 in 1975. And when you look at the data in 2014, they were at position number 3. China at position number 1, United States in position number 2, and India in position number 3. So as we had postulated and shown a decade and a half earlier, overall women are obeser than in men, at least in the subcontinent. And so obviously, this has to be factored in once we are treating these women. What social factors lead to it, what dietary factors lead to it. Is there something got to do with our culture that ladies have to be confined to homes only? Whatever. But this is something that we need to understand. There is a difference. Now, as I was just now trying to allude, looking at that diabetes in relation to obesity or otherwise, in adolescence, there are major biopsychosocial changes like menstrual cycle and the obesity striking at that time. Then reproductive years, as I was just now telling you in my introductory slide. But transitional years, till very late, life expectancy used to be 50 to 55. Menopause would usually occur in most of the women between 53 and 55. unless there was a premature menopause. So many women would not live a long life after menopause. But now life expectancy has increased, and women can expect now to live 1/3 of their life in a post-menopausal state. It comes at its own cost, which I will dwell on. Then in these transitional years, psychosocial changes, women happen to be more dependent than men, economically, socially, or otherwise. And there are lots of women now who live till a very old age. Disability comes with old age. The disability comes with diabetes, problems with the eyes, problems with the joints, problems with the hip. Then poverty and lack of social support. The men, so long as they live, have something to bank on because they have been working, and no, their incomes might dwindle, but something keeps on supporting them. But women, many times, children moving out of homes, going from villages to cities, or for a job elsewhere, that social support is not as vigorous today as it used to be. So those are the factors also. So that will have a direct impact on the management. Now, this is very important to understand. If you look at the beginning of this trajectory, look at that small little frail girl, a beautiful unmarried girl at 22, 23, weight perfect, 50, 52, 53, with a height of 5'2", 5'3", 5'4", max 5'6", gets pregnant, and every individual gains some weight during pregnancy, which is known as gestational weight gain. And there are norms which tell us whether your gestational weight gain is appropriate or is less than normal, which has its own issues, or is more than normal, which has its own issues. But what is relevant, that whatever age, whatever weight women gain during pregnancy, it should be shed before the next pregnancy, so that they achieve a metabolic milieu that was existent prior to the pregnancy. But in real life, what happens? Most of the women end up in continuing to have that weight gain that they acquired during pregnancy. And when they reach the second pregnancy, they come with a totally different metabolic milieu, a central adiposity, and the consequences of that central adiposity. And then they become sort of predisposed to IGT, IFG, gestational diabetes, and dyslipidemias, whatever central adiposity can do. And as the pregnancies go on, this gestational weight gain keeps on getting worse and worse, and predisposing to everything that an obese person can have: coronary artery disease, dyslipidemia, diabetes, joint problems, spinal problems. And then there is no limit to the trajectory of pregnancies in our country, particularly in the rural area, where apart from diabetic health, metabolic health, the bone health is not appropriate, hygiene is not appropriate. So then many things get complicated. Now, I'm sure all of us have heard of polycystic ovarian syndrome in the recent times. Currently, it is believed that this probably is the most important endocrinopathy in women. And if you look at the etiopathogenesis of this syndrome, it has been shown to be characterized by insulin resistance. Now, insulin resistance gives rise to hyperinsulinemia, which has been shown to decrease from liver sex hormone binding protein. So free testosterone goes up, so you start getting some amount of hirsutism, facial or otherwise in the body, acne, which does not respond to the conventional treatment. And this also reduces the IGF binding protein, insulin-like growth hormone binding protein, and free IGF goes high. That causes ovarian stimulation. And there are many mechanisms that have been postulated for it, but The basic concept is that these women, at least the significant number of these women, have insulin resistance, so are predisposed to ultimately beta cell dysfunction, pre-diabetes, and diabetes. What is different is when we look at polycystic ovarian syndrome, the prevalence described can be different in different societies depending on what criterion we use. But when we look at a person with polycystic ovarian syndrome, now I'll give an example. Let us look. This is the data that we published about infertility. Now we found out that if you look at female component, the most important female component for primary infertility was anovulation, which would be more in tune with polycystic ovarian syndrome. Now, when they come to us when they are young, we look at that cosmetic component of hirsutism. When they come to us when they are married, we look at the fertility component. But we as physicians never look at the direct impact of health on this, because this is a lady, as I just now told you, is predisposed to diabetes. 40% of these women will have diabetes by 40th birthday if we don't intervene. So if we get this information at 16 years only, this young, beautiful, fattish girl has polycystic ovarian syndrome, we never counsel them that apart from this cosmetics, apart from conjugal life, apart from fertility, we also are predisposed to diabetes. 75% of them will have significant dyslipidemia, so predisposed to coronary artery disease rather early, hypertension, and other components of metabolic syndrome that we refer to. But we never consider that as a sickness. We'll be ovulating them, we'll be getting them pregnant, their obesity will be getting worse, which is very right to do. But simultaneously, the other part of the counseling that this is what is important for your health needs to be told. We see a lot of women with primary or idiopathic hirsutism, so common in northern India. After idiopathic hirsutism, the commonest cause is polycystic ovarian syndrome. Many times what I have seen all these decades of my endocrine practice, these girls are only educated about the cosmetics, how to do electrolysis of this, how to get rid of this additional hair, how to make your face fairer. But it's fine, that part we continue doing. But simultaneously look at the underlying basic etiological mechanisms, so that we start modifying the metabolic component of this disease a decade earlier, because you get an information about it a decade earlier. You are aware of it, knowledge is there. So that's what I'm saying, this insight needs to be developed. Now look at the trajectory that I already showed you. Now, as I was telling you about polycystic ovarian syndrome, a polycystic girl before marriage is like that. If you look at the bottom of this trajectory, the second girl that is what is the body's architecture before marriage. So she comes with that metabolic load already there. And with every pregnancy, this gets worse rather than better. So this also needs to be understood. This is a paper that we published in Reproductive Biology and Endocrinology about a decade back. Very simple, if obesity was related to insulin resistance, then if you look at pure, uncomplicated type 2 diabetes mellitus in women and reproductive age, we compared women with diabetes and without diabetes, and were surprised to see that polycystic ovarian morphology was twice as common in diabetic girls than in non-diabetic women. Again, tells us that there is a huge relationship between the two, that you and me as healthcare providers need to understand. Diabetes and pregnancy, hyperglycemia in pregnancy is becoming a huge issue for two reasons. One, it also prognosticates for the mother how well the fetus will go. But this also primes this individual, how this person's personal life would go. If you don't treat it well, how it primes different cells for diabetes in this particular infant. And if this infant happens to be a female, this is likely to impact the next generation as well. So her own kids would be predisposed to it. I'll not get into that in view of the time. So different studies have shown different prevalences. But probably one of the reasons why these different prevalences have come, our age at marriage used to be pretty low in the subcontinent. In India, girls used to get married at 14, 15 years of age. People will have a kid at 16, 17, and 18. And look at this, our data that we published. If you have your baby before 25th birthday, and in the olden times, most of the ladies would have quite few babies by then, prevalence would be very low. But if you get married after 35th birthday, prevalence would be almost 20%. And this 30 to 35 is no common age in our metropolitan cities. Those are the girls also who have obesity. That segment of population also will be predisposed to polycystic ovarian disease. So this will be almost 1/4 would have a problem. They will have a problem, their children will have a problem, and if this kid is a female, the subsequent generation will have a problem. This insight needs to be developed. For long, we thought that women, the coronary artery disease is less common, less vigorous than men. Male sex in itself being one of the predisposing factors. But once come the diabetes, is a very powerful risk factor for coronary artery disease in women as well. Framingham Heart Study has shown it. Nurses Health Study has shown it. Look at the mortality data of IDF. Deaths far more commoner in women than in men. Probably the resource allocation diversion towards females rather lesser. There's some data that we published about mortality in diabetes, the decades data in 1998. And this study we replicated a decade later. We showed that over these decades, the diabetes care has improved, but infections and chronic kidney disease keeps on killing lots and lots of people. But what stunned me between the two studies, in the first study, very few type 1 diabetics survived to the 40th birthday. But in second part of the study, many individuals with type 1 diabetes in our institution made it to the 50th birthday. But they were predominantly males. And the average life expectancy of a female type 1 diabetes was just 27 years. So there's this social polarization of allocation of familial resources, more towards a male child than a female child. So the difference has not vanished yet. We're talking about it, we are not actually implementing it. Socio-cultural barriers, we know. Obesity in many homes is not considered as, they think is a healthy child, which we, particularly females, that perception needs to be changed. And very rigid social and cultural norms. Many times I tell a lady you should do some exercise, and they start giggling, as if I tell them you need to walk on the street without clothes. I'm so like, they feel it very odd what is it this doctor is saying. So the time has come that we need to homogenize whatever is good for men is good for women as well, at least so long as diabetes is concerned. A lot of psychosocial problems, we have seen it so often as endocrinologists, and men are now coming for the last couple of decades and getting properly treated, either with depression or with, if there's a physical cause of sexual dysfunction, but similar problems in women. And now that diabetes comes early, can strike these issues very early, and it can make a human being very bitter. Conjugal life can be compromised. So this is again something that mechanisms need to be found to explore this psychosexual behavior of women and address the issues that emerge there. So I personally believe, before I conclude, that healthcare systems should consider custom designed prevention and control programs which are tailor-made for women, particularly in societies like ours, where still, in spite of whatever jargon we say, we still continue to live with a lot of taboos, a lot of differences, where that homogenization of many things is yet to occur. And I think the key is education. Women need to be educated. Educate a women not only in terms of whatever conventional education we are talking about healthcare, about diet. If she gets convinced, it is not only you are treating her, you are treating that whole family. And if she's able to provide a diet of the quality that you and me want them to prepare for a diabetic patient, the family would be having appropriate corrections in their diet. So incidentally, many factors that lead to metabolic disorders would be taken care of. We have been so far brushing aside and not coming to the fore with the issues. but probably time has come that we slowly need to open up, not brazenly. We slowly need to open up and talk about the issues so that those issues can be addressed. Thank you so much. Over to my friend.
Thank you, sir. Thank you so much. I would like to speak to Mr. Rajiv Agrawala, sir, to start the session.
Thank you, Dr. Zargar. It is always a pleasure to listen to you, and why I say so, you had been professor of endocrinology, so you can profess so many things which are almost dictates in endocrinology oblique medicine. It is always a pleasure to listen to you and to understand the finesses of endocrinology. As Dr. Jargar said that he had an experience for 4 decades, I'll say I have an experience of cardiology for 3 decades, so I'll also have something to profess. Just a minute, just a minute. Hello? Jaldi. अच्छा ठीक है थोड़ी देर में. I'm sorry, I had a hospital call. So Dr. Zargar is always so emphatic with clarity of ideas that I'll say, let me use my 3 decades of experience and express how cardiologists look at diabetes. As you know, diabetes is a big nuisance for endocrinologists and cardiologists alike, or anybody who deals with vascular medicine. It shortens life, and more so when it is combined with vascular compartment problems. As you know, the rate of CV death is increased by 50% in those with diabetes. Many of us know diabetes causes more of atherosclerosis, and because of our endocrinologist colleague and EMPA-REG outcome, we realized the bigger nuisance is cardiac failure. The fear and the problems of cardiac failure in diabetics is more than atherosclerosis. And I'll be showing you some data that whatever we may do, the mortality in diabetics continue to be twice as that of non-diabetics. So it reduces life by 7.8 years and 8.4 years in men and women, and it gets extended. Loss of life gets extended if it is associated with cardiovascular disease. That is one major challenge. And today, when I look participation of clinicians, internal medicine people, cardiologists, nephrologists, endocrinologists, it looked like an old story of big elephant, everybody touching some part of it and saying the shape of elephant is like this. And that is why this platform is unique, that endocrinologists, cardiologists, nephrologists, internists have to define the problem, size, contour of the problem. And that is why we are creating now more and more interface between cardiology and endocrinology, internal medicine, and nephrology. When we talk about cardiology, I always remember 2 simple words. There are 3 macrovascular beds. The macrovascular bed are cardiovascular, cerebrovascular, and peripheral arterial disease, and 3 microvascular. Microvascular, I mean, is nephropathy, ischemic neuropathy, and microangiopathy, and retinopathy. So there are 3 macro and 3 microvascular beds. The microvascular is retinopathy, nephropathy, and ischemic neuropathy. So these 2 simple words will make my story very, very simple, realistic, and clinical. And as Dr. Zargar has shown, the diabetes has gone up, improving its standing from 14th disease to 10th disease in the world. There is 6.5% increase in deaths per 100,000 people. And if you look at it, majority causes of death due to diabetes is vascular, whether it is renal, cardiovascular, peripheral, neurological, ophthalmic. So it is 90% of the death burden is related to vascular compartment. And this is the reflection of vascular compartment acute injury, renal replacement, progressive chronic kidney disease, heart failure, which may be a manifestation of ischemic cardiomyopathy because of macroangiopathy related to cardiovascular coronary arteries, or microangiopathy, what we describe as cardiomyopathy, myocardial infarction, stroke, hospitalization, and death. This is just a cartoon I recently came across in my in my WhatsApp group. It is a Maximus diabeticus triglyceridus hypertensus. It's just nothing but a pictorial depiction of overweight. That means obesity and diabetes, triglyceride, and hypertension, which are, I'll say, pillars of the disease burden related to diabetes. Another thing which is very important, Dr. Zargar keeps on showing us the dangerous trends in obesity and his enormous work related to obesity. Obesity sees no gender, no country, even lower socioeconomic people are suffering from obesity. In India, it is a very peculiar problem. As you advance in seniority, as you advance in authority, overweight is taken part of your authority, because now you say, I am sedentary, and this gentleman was same as the gentleman, as the young man on the right side, but obesity he has succumbed to obesity over a period of time. All of you know that diabetes is a coronary risk equivalent. Patients who have diabetes and patients who have cardiovascular accident or MI, their risk is same in terms of event rate per 1,000 person years, both in men and women. And that's why we started talking since 98. This is Dr. Hafner's work, that diabetes is coronary artery equivalent. It accelerates atherosclerosis. Peripheral arterial disease is very, very common and is the most common cause of traumatic lower limb amputation. Strokes are also increased. Why, as a cardiologist, we are interested in diabetes? In diabetic atheroma is different. There is more of inflammation. You can see macrophage infiltration. There is causing inflammation. It causes neovascularization and increased collagen layout in diabetic plaque, which is seen in the histopathology slide. So inflammation at one hand causes acute coronary syndrome. Neovascularization and collagen 3 layout causes restenosis. So there is more events and less success. This is one of the slides I have recently taken from Mayo Clinic's proceedings, and it shows what Dr. Zargar had been insisting. Insulin resistance is one of the triggers for PI gene expression, resulting in increased level of PI, increased thrombogenicity, what we see in diabetes. This is a slide which I just got a couple of days back, and very, very descriptive clinical slide. If you have simple diabetes, all-cause mortality is 1.9 times, stroke 2.1, MI 2, diabetes and MI 3.7, diabetes and stroke 3.8, stroke and MI 3.5, and if diabetes, stroke, and MI happen, then the risk is 7 times. And that is why cardiologists are very worried about if there is macrovascular involvement, and especially if there are more than one VAD involved, what we call is polyvascular disease. So if you have MI with peripheral arterial disease, he is a dangerous patient. If a stroke with peripheral arterial disease, he's a dangerous patient. I don't have the time and opportunity to talk about how we reduce the risk in these polyvascular disease patients, but once again emphasize a simple clinical tool that the number of vascular VAD involved translates in diabetes into multiplication of risk in coronary events. And the risk is directly proportionate to the level of glucose from risk event prior to diagnosis of diabetes. And if you have frank diabetes, there is incremental, linear, progressive risk relation. This slide I showed you is a historical slide I talked about briefly earlier also, and just trying to emphasize the vascular biologists or vascular clinicians suffer from this problem, because whatever you do, whatever the advancements are there in cardiovascular medicine, the mortality in diabetes is double even today. It is reduced, but it is double. The issue which has come lately to our understanding is cardiac failure. You know, it is more common than atherosclerosis. Every 1% increase in HbA1c translates into 15% increase in risk of developing heart failure. So there may be two kinds of cardiomyopathy: ischemic related to macrovascular disease, or microvascular disease related to microangiopathy of the capillaries, leading on to cardiomyopathy, which we described as idiopathic diabetic cardiomyopathy with normal coronary arteries. And no opportunity to talk about. Diabetes affects the cardiomyocyte, fibroblast, and endothelial cell, causing all kind of negative loop. And there is systolic dysfunction, diastolic dysfunction, combination of that. You make a heart stiffer because of the fibroblast, endothelial dysfunction. So heart failure with preserved ejection fraction is a reality in diabetic hypertensive individuals. There is long-term mortality increase related to pre-diabetes and diabetes, development of heart failure and heart failure hospitalization, all-cause mortality and cardiovascular mortality. They all correlate with the risk of glucose burden. If I look at 5 years down the line, patients who are clinically fine and are just so-called simple diabetic, you will find that only 32% of the patients are having normal LV function. They may have diastolic dysfunction, they may have systolic dysfunction, and they may have a combination of two. So 2/3 of our patients down the line, just 5 years in diabetic natural history, are prone for heart failure. That is the burden of diabetes. How I clinically integrate all this information. As endocrinologist, you know more than what I know, but it always fascinates me what Dr. Zargar showed: insulin resistant leading on to hyperinsulinemia, over a period of time, beta function death, beta cell death, and rising glucose, microvascular compartment involvement. But the beauty is you have to understand the macrovascular involvement starts before microvascular. Macrovascular causes sudden death. Microvascular causes debilitating diseases, long drawn. So a patient who has got retinopathy in all probability will have cardiac involvement. That is the message. The vice versa may not be true. So let us understand this game, that if you have nephropathy, don't forget that he is late in the natural history and he might be a candidate for stroke or cardiac event, or he may have peripheral arterial disease. So when you come across microangiopathy in terms of albuminuria, ischemic neuropathy, my neurologist colleague handling, or retinopathy, when ophthalmologists are undertaking these patients, never forget macrovascular complication. And this is a slide, I'll dwell upon it again over a period of time in my communication to you. This is again very important slide showing that child born out of diabetic parent is still having, without dysglycemia, endothelial dysfunction. That means the endothelial dysfunction precedes glycemia, although hyperinsulinemia is often seen in these patients. And it creates a hypothesis that hyperinsulinemia is more noxious, causes endothelial dysfunction, and it precedes dysglycemia. And that you have to carry home and remember always that dysglycemia, you are entering the last part of the natural history. And this is Dr. Kraft's work. I had been working on it. Those who are interested, I'll request to spend 7 minutes, Google Kraft and insulin assay. He's a pathologist from Chicago, based in New Zealand now, and does wonderful work on insulin assay, and he refers to Kimmelstein-Wilson's work, what we know KW syndrome. But this Kimmelstein work is same, as he shows that the damage precedes the point where the glucose becomes elevated. That means the kidney lesions also start before dysglycemia, and there is a mechanism, there is a loop which activates hyperinsulinemia, insulin resistance, and injury, which is followed by dysglycemia. I'm going to show you some of the population studies which shows if you have 3 microvascular bed, that means retinopathy, neuropathy, and nephropathy, the risk involvement is more than any risk factor known, because you are likely to develop macrovascular disease in this patient, and there is a linear correlation of risk between the number of microvascular bed involved, as I showed you in macrovascular bed. So very simple clinical tool. Ask when you examine a patient of diabetes, how many macrovascular beds are involved? How many microvascular beds are involved? If 2 microvascular beds are involved, macrovascular beds have to be involved, and I have to be more aggressive. And it is better than any risk factor you can see in this graph. And this is the essence of management of vascular involvement in diabetes. And this is just not theory. Does the microvascular hit promote macrovascular disease? I'll say no. It precedes the microvascular involvement, and that is how we look at it. It predicts increased cardiovascular events. Diabetic patients who have retinopathy are known to have more plaque vulnerability in acute coronary syndrome, which is very, very simple to understand if you understand my game plan of 3 microvascular and 3 macrovascular bed involvement. Again, if you give a statin in diabetic retinopathy, you do better than a non-statin patient, even in retinopathy. So retinal laser treatment, proliferative diabetic treatment, all diabetic retinopathy, non-proliferative diabetic retinopathy, they do better with the statin. Leave aside their positive effects on macrovascular involvement. So educate your ophthalmologist colleague that statin are needed in diabetic retinopathy. Another thing which I recently came across from my colleagues who do bariatric surgery, that microvascular complications are reduced even by bariatric surgery. So when we combine microvascular compartment, this is Dr. Milton Packard's work that shows the microvascular disease involvement, there is heart failure progression, and he keeps on to say that probably dysglycemia, heart failure, and nephropathy, these 3 things go together, what we describe as classical microangiopathic vascular syndrome. And that's why whether you take SGLT2 receptor inhibitors or Vimada, these drugs, they improve GFR, they improve glycemia, and they improve cardiovascular and renal outcome. So there is some kind of common loop between these three things, and these drugs are affecting all of them equally well. So how I look my diabetes, who is at more risk, long duration, albuminuria, GFR, retinopathy, neuropathy, and ABI, as I told you, peripheral arterial disease, again simplifying 3 macrovascular bed and 3 microvasculars. What is the mechanistics? In the world, for the first time, 2005, underweight equal to overweight. As Dr. Zargar showed, that obesity correlates with diabetes. You can see this. And this is Dr. Jocelyn in 1927. Excess of fat, diabetes begin, and excess of fat, diabetics die. And when the fat excess happens, these fat cells, they grow in size, they become crown-like structure, what is called CLS, and they are macrophages. And these cells, they become secretory. Fat cells are not supposed to be secretory in healthy state, but as they grow in size, they become secretory, and they cause all kind of noxious agent being released by them, and they cause inflammation and anything you know in diabetes. So there is progressive obesity leading on to adiposity, progressing to adiposopathy, which is nothing but fat tissue which is inflamed and causes hyperinsulinemia, insulin resistance, and everything you know in diabetes vascular compartment disease syndrome. And that is what happens, that drowning of fat is reduced when these fat cells become inflammatory. There is more of fibrosis and there is increased insulin sensitivity. This is just what is insulin resistance. You start passing more in urine, and insulin is the key by which the glucose goes in. And this you see, when the fat cells become inflamed, they produce horrifying number of inflammatory markers, which shifts insulin's axis. I'm going to show you what is the pathological insulin axis. And this is a paper which shows in diabetes, the risk of stroke is independent of atrial fibrillation, because I showed you the pi levels are increased. It causes systemic inflammation. So you can have stroke in diabetes without AF. What is the natural history? Hyperinsulinemia, dyslipidemia, atherosclerosis. This is symptom-free normoglycemic state. And 5 years in the last phase of natural history of diabetes, you have dysglycemia. And we are talking about 15 years back on the left side of the graph, where hyperinsulinemia, which is a silent player, but very noxious, deceptive player. And this is a master article you should read, all of you, integrated view by Dr. Muniappa. And what he shows that insulin has got two limbs. In short term, the right limb is activated, it causes vasodilatation and glucose uptake. But over a period of time, prolonged exposure and inflammation, the insulin axis is changed and it causes mitogenesis, fibrogenesis, and vasoconstriction, and insulin becomes atherogenic. So insulin is not atheroprotective in long term, it is atherogenic, and you can see that there is on the left side a healthy skeletal muscle and endothelium. On the right side, metabolic and cardiac disease, endothelial dysfunction because of insulin and insulin resistance. Skeletal muscles do not take glucose any longer. So this is Dr. Muniappa's exceptional work, which shows that inflammation, insulin adopts a different loop on the left side and becomes atherogenic. And when you use statin, there is increased insulin resistance, and that is why with the statin usage, you find there is increase in new onset hyperglycemia. If hyperglycemia is there, many of you come across diabetic muscle fatigue, idiopathic muscle fatigue. The reason is these insulinemia, hyperinsulinemia, and inflammation does not permit adaptation to happen in the skeletal muscle. So same level of exercise, you do not develop capillaries, oxidative fibers, glycotic fibers with increased exercise capacity. So we know why our diabetic patients are not able to exercise well. Going back again to the same slide what I showed you, you show that in type 2 diabetes, there is no insulin deficiency. There is hyperinsulinemia, unlike type 1, and insulin, which is normal pancreas, there is overproduction, as Dr. Zarga said, that it is insulin resistance. And this is Dr. Kraft's work, and exceptional work. All endocrinologists are requested to go through this work. This is a lecture on YouTube. You can download and see it. It will change your understanding of diabetes. Dr. Kraft says we follow only the glucose in glucose tolerance test. We should follow the insulin level. If at 2 hours they are more than 40, then you are hyperinsulinemic. And he says that unfortunately the definition of diabetes is glucocentric. Unless it is made vasculocentric, people will not think of diabetes as a vascular disease. And he wants to bring in insulin level. They may be unrealistic, not cost effective, but he says that if you measure simple glucose, you miss so many patients who are compensated in terms of their glucose level but have very high insulin level. He described these terms as diabetic in situ. This is Dr. Kraft's work. And these are insulinopenic patients, which are type 1 patients. If you use hyperglycemia test, the sensitivity is just 52%, while they still have hyperinsulinemia. So Dr. Kraft says those with cardiovascular disease are not identified with diabetes, they are simply undiagnosed. And I'll say we need to change the definition of diabetes. I call upon people like Dr. Zerger who are in academia to think of it, or we are supposed to change the definition of diabetes from glucocentric to vasculocentric. Although it is all negativity, but CVD deaths are dropping, but the problem happening, what Dr. Zargar has shown, that obesity is increases. So overall obesity is increasing, but the number of deaths in diabetes related to cardiovascular disease in last 3 decades is decreasing. And Dr. Braunwald, who is a father figure in cardiology, says that each one of us should understand now diabetes and vascular medicine. Cardiologists are challenged to learn vascular medicine. That's why, despite being intervention cardiologist, I am here to share with you some of my thoughts on vascular compartment. So, ladies and gentlemen, I'm going to close. Diabetes is a polyvascular disease. Learn to score the diabetes to prognosticate in terms of atherosclerosis, in terms of cardiovascular disease, and individualize the newer drugs like SGLT2 and GLP-1 receptor, and understand and never underestimate the risk of cardiac failure in, in patients who have diabetes, and there should be a priority consideration by individualizing therapy. The exercise and diet will never go away from management of diabetes, and take every opportunity to exercise. So never forget, we need to take care of diabetes by taking care of diet and exercise. And that is all I wanted to share. I think I have crossed over a little bit, not too much. And I'll invite now questions along with Dr. Zargar. Thank you very much.
Rajiv, that was a wonderful talk, but I think we have already taken the call on what Eugene Brandwald wants us to do.
Yes.
So we have been collaborating more often in the recent years.
Yes, yes, I agree. I agree, sir.
One comment on your last but one slide, the diabetes, cardiovascular disease, and what happens with insulin resistance.
Yes, yes.
In fact, if you go back,
yes.
In 93 decades back, there was a paper published in Diabetology looking at pre-diabetes.
Yes.
And this study was known as Paris Prospective Trial.
Yeah.
What this Paris Prospective Trial that time showed was that a person who has pre-diabetes may or may not develop diabetes.
Yes.
The chances of developing a coronary artery disease is 3 to 5-fold more.
Yes.
So it had already shown that even in pre-diabetes, coronary artery disease is 3 to 5-fold more.
Yeah.
And it is because of these data only that people started lowering the figure for diagnosing diabetes from 140 to 126, and then creating a category of pre-diabetes so that you pick them up as early as possible, so that more and more of those diabetics who get missed, where insulin cannot be looked at, could be brought into the dragnet, and they could be given a consolidated cardiovascular protection.
Yes, sir.
That was one of the main reasons why the diagnostic criteria were changed, because insulin could not be tested in a clinical setting.
Yes.
Sugars could be. So from 140 going to 126 to 110, now 100 only.
Yeah.
Beyond that, the moment it goes above 101.
Yes. So Dr. Kraft says that if we combine these two things, our pickup goes, and he described what you describe as pre-diabetes. He coins the term diabetes in situ, where there is hyperinsulinemia and normal glucose tolerance test. And cardiovascular point of view, it's a very attractive hypothesis. It may not be the only reason. Hyperinsulinemia may not be the only reason, but it looks very attractive.
Yes,
So
any questions?
any questions?
Thank you, sir. Thank you, Jagar sir and Rajiv sir. We are having few questions.
Yeah.
Let's start. The first question was from CP Tiwari sir. What is the risk of diabetes complications regarding gender?
So it's a question to Dr. Zargar. I'm free.
You see, if you look at the intrinsic biology is, but as I was just now showing you the idea of data, mortality is more in women than in men. But I think this is not a difference in the biology, this is a difference in the resource allocation and the social perceptions on this globe. You know, when we are talking about a liberated this thing, we are looking at few patches of Western world, but most of the Asia, Latin America, and Africa has not changed. One. Number two, Rajiv elegantly explained to you the coronary artery disease, how it precedes almost a decade before even onset of diabetes. So it cannot be equated with microvascular disease. In premenopausal women, there is some sort of a protection because of her estrogens. But the moment she becomes diabetic, this protection is homogenized. So men and women have a similar profile in that. So intrinsically, no biological differences. Again, as I was telling you, in years to come, polycystic ovarian disease is going to be a very important, and in Western world, this is already the most frequent endocrinopathy in women. And this is something that starts occurring in the peripubertal period only. Now imagine somebody getting dyslipidemia in peripubertal period only. When somebody gets insulin resistance, one of the first things that happens, your TG starts going up. It may one day be 220 and 2 years later it is 320, which we as convention keep on neglecting. And then over a period of time, HDL starts dropping down. And then one fine day you find out LDL going up and then it starts catching your eye. So that is something that will modulate the natural history of the disease. But in the Indian subcontinent, we are not yet there. But we are heading fast towards that, that direction.
I think Dr. Zargar made a very, very important point. The natural history and course of the lipoproteins, the triglyceride, the HDL and the LDL, and they look so innocent, but they are the precursors of the disease, and vascular compartment is beginning to be affected by these agents. So when you have high TG and low HDL, what we call as phenotype B, you may be hyperinsulinemic, and that is the time you may coin any term, but you need lifestyle modification, decrease carbohydrates, exercise, weight reduction. I'll say, whenever I call my daughter, she is in America, ask her at least monthly, what is your weight? And being an American software engineer, she gets fast food because that is what she can eat. So as parents, our responsibility to ask our children, what is your weight? How you are doing? So, and this is very important responsibility, since we are coming from a poor times to a richer, affluent times. Asking and checking your children for food looks culturally very bad, but we have to adopt that kind of attitude.
Yes, next question.
Thank you, sir. Let's move to the second question. What is the most common cardiovascular complications associated with diabetes?
I'll say we talked about the risk of cardiac failure is more than the risk of atherosclerosis. 5 years back, I never used to have this understanding. It is our endocrinologist colleagues, empiric data, that we convinced ourselves that cardiac failure is a bigger problem. And the good thing is, you have to risk score these patients. When you see a diabetic patient, you have to do either a Framingham risk score or a JBS3 risk score or a ACC-AHA risk calculator. Similarly, you have to risk score for cardiac failure. We can do a ABC risk score, which is done in EMPA-REG outcomes. We can do a kind of magic risk score, MAGGIC magic, and this you can download from net. Or the latest is TIMI heart failure diabetes risk score from a TIMI group, which is most validated risk score. And I'll say, whenever it is like taking a vital sign of diabetes. Without scoring a diabetes, you can't start treating diabetes, because the choice of drug depends upon the risk scores. The statins, the aspirin, they are all individualized on the basis of risk scores.
Very aptly said by Rajiv. For a long time, we only used to talk about the aggressive coronary artery disease, the diffuse coronary artery disease, that inflammation that Rajiv referred to, and that unstable plaque because of that inflammatory component, more myocardial infarctions. But we never realized that there might be a component that we are missing. And whether it is ischemic in origin or it is some form of a microangiopathy that leads to some form of a diabetic cardiomyopathy, heart failures are an important issue. In many times, how blind you can get in spite of having such hordes of people over years and years and years by convention. And that's something, we need to desist from, to keep our eyes open. Heart failure, if a person has recurrent heart failure, has much worse prognosis than most of the malignancies today, the way they're getting treated. And if you look at total gamut of heart failure, 1/3 would occur in diabetic population, and they would have a much worse prognosis than the heart failure in non-diabetic population. So that's something that needs to be kept in mind while we try to assess the cardiovascular system in patients with diabetes. Next question.
Yes, sir. When we start insulin in chronic NIDDM patient?
I must tell you, there are many facets to it. Positive facets and negative facets. The first thing I must tell you, just now, I again would refer to Rajiv. He was talking about Jocelyn. And that is about 100 years back. When I am, Rajiv, imagine when they had hardly, you and me after decades could not properly think of heart failure.
Yes.
And when we have all the tools, when we have all the quantitative tools, not qualitative tools alone, quantitative in our own institution established. Imagine that fellow talking about obesity, about diet, about coronary artery disease. He did not have, he might have had some autopsy studies that I believe in. Insulin is something that cannot be taken away from diabetes, because this is something that has served diabetics for a good 100 years and has for the first time made people to live a respectable life with complications or without complications, but managed to live. Quality of life, quantity of life was increased. For good part of 3/4 of a century, only metformin and sulfonylureas were available. Fortunately for us in India, in rest of the world, even metformin was not available. And I think this is one of the collateral benefits of our official apathy, that metformin was not banned here, which was banned in the Western world in 1966. And I retrospectively think this is one of the bad decisions that has done a lot of good to lots and lots of our patients unwittingly. But today, we have hordes of drugs available. Ever since gliptins came in, the pattern of practice has changed. Ever since SGLT2s came in, literally, if not every month, every few months, a new aspect of diabetes and cardiovascular disease is understood and addressed. Not only understood, but addressed also. Now we have a huge barrage of GLP-1 receptor agonists. Amazing. Look at the leader trial. Give that, and this is probably the only diabetes drug that has been shown to alter the natural history of the atherosclerotic cardiovascular disease. Just following that. So you have amazing drugs today available. But as you know, for a long time, even American Diabetic Association used to give a very algorithmic fashion of how to treat people. Even in my younger days, I used to sometimes, young people are more revolting. Then how can they dictate how we treat a patient in India and treat a patient in Kashmir? And when I used to go to my town and those hordes of people dropping in my parents' home and treating those 100 guys, then first time in 2012, they said, give metformin if there is no contraindication, then whatever you give is your choice. Today, we have a huge choice with us, but in everybody's life, in every diabetic's life, if he lives long enough, he would need insulin one of those days. And he should, because not insulin as a drug, but insulin as a hormone which is deficient in the body and needs to be replaced. And that normal constituent getting replaced every time you look at a diabetic population. If you quickly want to get a diabetic control in a sick patient, in a hospitalized patient, in an ICU patient, in a patient for surgery, insulin is the answer. But I would give one advice. Getting more oral hypoglycemics gives a tendency to poorly control diabetes rather than start insulin on time. And every time we delay that, and on an average in the country, it is 3 to 5 years we delay insulinization. You create a further additional glycemic burden in the body, and that additional glycemic burden accelerates the already existing drivers for complications of diabetes. So that you need to make that appropriate time. After 2 or 3 oral hypoglycemics, if blood sugar is not controlled, basal insulin should be started. One single short word. Next. Yes.
I'll just come in. And since this is a unique opportunity to learn from Dr. Zargar as a cardiologist, we have a famous BARI 2D trial. My only caveat to or a rider what you have said is, if your glucose is controlled post angioplasty, post bypass by drugs, never try to bring in insulin for the sake it heals better. You have to give it. So large number of endocrinologist colleagues, when I interact with them, they say after angioplasty we gives for 6 weeks insulin. I said, for what? For bypass we give it for 3 months. I'll not name couple of big names. They say it is our protocol. Who are you to make a protocol? Where are the guidelines? So insulin should be used in every opportunity where it is needed, but should not be preponed for the sake of it that it is a better drug. No, it is not a better drug, but it is always wherever it is needed, as Dr. Zargar defined, should be used, but not preponed. That is my take as a vascular biologist.
Rajiv, there was a tendency to do so, what you were just now saying, when only sulfonylureas were available. And if you look at that glibenclamide era, its half-life was very unpredictable. And I belong to an era where, you used to use drugs that are a half-life of 72 hours.
Yeah.
Chloropropamide, it would have a half-life of 72 hours to 1 week. And that is the time, I'm talking about early 80s. People will be told, get easy on it, you get a hypoglycemia, you will get an acute event. I wouldn't know how to manage you. But that's why I said, currently, gliptins, beta-gliptins, SGLT2 inhibitors, GLP-1 receptor agonists. Now, in the Indian market, you will very soon have oral GLP-1 receptor agonists have a superb cardiovascular profile.
Yes.
And if with these drugs you have a good control, you have no reason to change.
That's a very big summary you have passed on.
That was an era of chloropropamide and glibenclamide. But I think that standard is buried now.
I was writing case sheet those times, never had an opportunity to write a prescription, so I have no understanding.
Next one. Any more questions?
Thank you so much, sir. We are having many more questions, but due to limited time, I wish to ask the last question. That is, if the parents is suffered from diabetes, how much percentage of diabetes occurred in his or her children?
You know, a lot depends. So I must first tell you that we are talking about type 2 diabetes predominantly,
Yes.
because type 1 diabetes is hardcore Dr. Zargar's issue, not Rajiv's issue.
Yes.
That's not a vascular disease. That is only hardcore beta cell destructive process in autoimmune disease.
Yes.
But in this particular, you know, there is a definite chance in siblings from quarter to 1/3. But I must tell you, I'll give a lot of difference comes from how different generations are living their life. My friend Rajev was just now telling you about our own children.
Yes.
I must, Rajev, tell you many times I would tell my wife, don't put more mutton on my child's plate. And she would tell them, Baap ke samne khana mat khao. I'm just telling you, I'm like, so she thinks ko nazar lagegi, baap hai ke. So, you know, this generational change is there. I live in Baramulla, which is the northernmost district of the country. Northernmost. The LOC is there. I live in a mohalla, born in a mohalla, which is Sardar Mohalla. Right? So one Sardar lady used to come to me. Her diabetes came in at 64th birthday, postmenopausal for 1.5 decades. And doing very well. She was 50 kgs, 49 kgs, 48 kgs. I kept on treating her for many years till I became director and couldn't go there. Her son, who was an SBI general manager in the town, developed diabetes at the age of 45. That daily developed, and his weight was 80. His weight was 88 kilos. Now this gentleman came with his younger brother at the age of 32 only, because his weight at 32 was 115 kilos. Genes have not changed. But once a parent has had it, this only means the sibling should insist on an appropriate lifestyle right from the word go, because chances are higher. Percentages may vary from different communities, different types of diabetes, but chances are higher. Like I was telling in polycystic ovarian disease, like I'm telling this family that is in my neighborhood in Baramulla. I told the Sardarji when he got diabetes at 32, I said, if your son is 100 kilos at 25, his diabetes would come at 22. Yes. So that's why, you know, we need to take care of that. And I'm happy that Rajev alluded to it, that how we need to keep watch on our coming generations. Yes. Rather than being too liberal with them. At least from health point of view, we need to repeatedly educate them. And I have found it a difficult proportion, Rajev, I must tell you.
No.
Both of them happen to be doctors, but, you know, educating on diet and exercise is proving a hassle.
That is true, but that is our responsibility. Keep trying.
Yes. I request our sales and the marketing head for vote of thanks.
Thank you so much, Dr. Zargar. Thank you so much, Dr. Agarwal. It was a pleasure having you all on board today and for sparing your very valuable time and for gracing this occasion and for sharing new insights. And I believe everybody would have got a lot of insights and learning today. I would also like to extend a lot of thanks to all the participants today who have spared the time in these difficult times. As we all know that the whole world is struggling, and hats off to all the Corona warriors, as we are telling them today. And this is a platform I would like to extend a thank on behalf of our organization. I would also like to thank our international doctors as well as our international team, which has spared their time in spite of a lot of timeline differences to participate in today's webinar and for making it a success. And last but not the least, it would not have been possible without the support of our support staff as well as teams on the ground. We have 2 divisions in India and both have worked tirelessly to make this evening a success. And this is just an initiation. It is a very small step from our side, and we look forward to many more in the future. And with your blessings and your guidance, we would like to take it further. And I would also take this platform to have a lot of suggestions and feedback as to how we can grow and get bigger and better. Thank you so much once again from the bottom of my heart.
Thank you, Dr. Zargar. Thank you, Dr. Zargar.
Thank you so much.
Pleasure.
Thank you so much.
It is always
Anita, I,
pleasure.
must, I express my gratitude that you gave an opportunity to me to meet my friend, which we had not done for quite a few months.
Yes.
Thank you so much.